Okay, and I don't have Ashlyn here today, so I'm not sure when you will get the video up, but it'll be in a few days. Okay, let me get my screen. All right. Here we go. Okay. Welcome, everybody, to Sunday Mornings with Twitchy Woman. Today we have Dr. Jaime MartinHatch from Synapticure, and she is going to talk to us about telemedicine and about the company she founded. She's a physician scientist with experience in basic and clinical research, movement disorders, and telehealth, and is involved at the local, national, and international level in advancing telemedicine for the care of patients, including starting the first telemovement clinic for movement disorders patients in Georgia. She served on numerous committees focused on telehealth for the American Academy of Neurology and the International Parkinson's Disease and Movement Disorders Society, and on and on and on and on. She will tell you more about herself as she goes on. So I want to welcome you, Jaime. I'm going to stop sharing my screen and you can share yours. Thank you.
Hi, everyone. Thank you so much for joining me today. Give me just a second. I'm going to share. Okay, can you all see my screen?
Yep.
Oh, somebody's shaking their head. No, they cannot see it.
You should be. No?
Sharon, you're able to see it?
I see it.
Okay. So my name, like Sharon mentioned, my name is Jaime Hatcher Martin. I am here to talk to you a little bit about a company that I've been working with over the past little over a year now, that's really focused on providing comprehensive care for people with Parkinson's disease, regardless of where they live. That company is called Synapticure. So just to tell you a little bit about myself, as Sharon mentioned, I am a physician scientist. I started off with very basic science research looking at pesticide exposure and other environmental factors in the role in Parkinson's disease. And I did all of my training, clinical training at Emory University in Atlanta, where I stayed until 2019. And currently, I am the director of movement disorders for this company, Synapticure, which you'll hear about today. I got involved in telemedicine actually back in around 2015 is when I started really kind of thinking about a clinic. And then in 2016, I opened a telemedicine clinic for patients with movement disorders. As I mentioned, I lived right outside of Atlanta, but I was working in Emory. And a lot of our patients would have to drive significant distances from Southern Georgia. We had patients coming in from Alabama, Mississippi. And at the time, you weren't allowed to see people in their homes. So we still had to have them come into a clinic, but I was able to start a clinic at the border of the Georgia and Alabama. And so patients could cut down on their commute times by 2.5 to 3 hours. And it was in a clinic that was often local to their community for a lot of people. So as part of my involvement with that, and really the goal was to improve access for people because a lot of my patients either couldn't drive or they didn't feel comfortable driving in Atlanta traffic. I had patients that actually lived in Atlanta that would prefer to drive out to go to the border instead of coming into Atlanta traffic. So it really was just about, getting access for people. And, at the time, a lot of our training was done, we do all these rating scales that you may have if you go to a movement disorders clinic, all of our research trials, all of this, the training was done by video. And every time a patient would call and say, hey, listen, I'm doing this funny thing, I would say, well, is it a tremor or is it dyskinesia? And they're like, I don't really know. Send me a video. So we did so much by video, and so much of the visit and the exam is not based on specifically what's happening in that moment, but what's been happening over the last few months, right? It's not just that moment in time. And so it's for that reason that I really started getting involved. And as Sharon had already mentioned, I've been on numerous different telehealth committees and subcommittees for the American Academy of Neurology, and then the International Parkinson's Disease and Movement Disorder Society as well. And obviously with the COVID pandemic, then obviously telemedicine sort of exploded. And so I was really happy to already be involved in that space. And then I've also just been involved in a lot of advocacy. I've had both at the state and the national level. I've had the opportunity to attend a few different programs, one of them being Neurology on the Hill, which is a program with the American Academy of Neurology, where we go to talk to, we have neurologists that come from all 50 states, and we get to talk to our senators and Congress people about issues that are important for people with neurological disorders, and neurologists as well. And then I've been involved through several of the advocacy groups. And this is my family. We do a lot of the local stuff. So this is one of the Parkinson's Foundation walks, my husband and my 2 boys.
Guys, stop.
Was that somebody else?
Yeah. Okay.
Okay, so I feel like I'm probably preaching to the choir for a lot of people, but for many people that have neurodegenerative diseases, whether it's Parkinson's disease or Alzheimer's disease, especially if you're not the classic textbook definition of what the disease is, the journey can be often expensive, it can be complex and difficult to get a diagnosis. We often hear, especially with women with Parkinson's disease, that sometimes their symptoms are dismissed or they're kind of blown off as something different. And so it can be really difficult. And so for many, many people, it can take a long time to get to the diagnosis. They may have to travel significant distances if they are referred to a movement disorders clinic. And in some cases, just to go to a general neurology clinic. And for many neurologists, and especially some of the subspecialty clinics, the wait times can be 6 to 9 months or more to get a new appointment. I just had another patient who was trying to book appointment locally, and they're about 14 months out right now. So what happens during that time is there can often be a lot of duplicative tests, maybe unnecessary procedures. I can't tell you how many patients have had hip surgeries and back surgeries because maybe they don't swing one leg as much, or maybe they have some tightness in their hip. And so they go through a lot of different imaging and sometimes some unnecessary surgical procedures in order to try to get to that diagnosis. If you are able to get in to see a neurologist or hopefully a movement disorder specialist, often the visits are every 3 to 4 months or maybe even longer in between, unless you're part of a trial. And one of the biggest issues is there's often limited access between visits. And when I worked at Emory, we have a huge movement disorders program. At the time when I was there, we had 18 different physicians, and we were stuffed to the gills. We didn't have, if I wanted to bring somebody in, if something urgent came up, I didn't have space in my schedule to do that. We didn't have built-in time for that. And I was booking out 10 months. So there was just no way to, and so a lot of it, again, was back to this, well, send me a video, let's hop on a quick video so I can see what's going on to try to address a lot of these issues between visits. So it's really frustrating for both patients and their care partners, but also on the physician side as well. So what happens is a lot of people end up sort of dropping out of, trying to go to some of the bigger centers because often there's significant wait times. Goodness forbid you have to change an appointment or your appointment gets canceled and now you've got to wait even further. And so what ends up happening is a lot of people end up not seeking specialty care, and then they end up returning, to the hospital or to an urgent care with some sort of emergency or a fall or some other issue that many times, at least potentially could have been avoided if we had addressed those issues at the outset instead of waiting until things got bad enough that they ended up in the hospital. And one of the biggest complaints that we hear from patients, but again, also from physicians, is it's really difficult for patients to access care in their home. Sometimes as things progress, it's harder and harder to get out. And then for a lot of our patients, I'm apologizing right now. There's a huge storm outside. So if you see lights flickering, our electricity is flickering right now. So a lot of patients, and this applies probably more to some of the other diseases that we see in our clinic, but as they transition to end of life care, a lot of our patients that transfer to hospice, they feel like they end up being abandoned because they feel like they have to give up a lot of their physicians. They can't make it to those appointments anymore. And so this becomes a time where they really feel like this is when they need care the most, and then they feel like they're not able to get that. So what we hear a lot from both patients and their care teams is that they really feel like they're left to advocate for themselves, that they have to be their own quarterback. And it can really feel like a full-time job, right? And for many people, especially in the beginning, right, you're just trying to manage and deal with just the concept of a new diagnosis. And, if you're still working or you're managing other things, trying to navigate this, deal with all the things in your regular life, try to keep up with all the PT and the OT and all these things that you're supposed to be doing can really be difficult. So, specifically for Parkinson's disease, this is a growing issue because there is a growing shortage of neurologists in the US. It's getting worse and worse. And right now there's an estimated 1 million people in the US living with Parkinson's. And that number is probably an underestimate. There was actually, so the quote up until a few months ago was always there's 60,000 new diagnoses of Parkinson's in the US every year. But a recent study that just came out said actually it's probably closer to 90. And so we suspect that 1 million Americans living with PD is also probably an underestimate. And what's really concerning is that another recent study showed that about 40% of people who have Medicare, at least, actually don't even see a neurologist. So this isn't even movement disorders neurology, but actually don't even see a neurologist because they have so much difficulty accessing care. And then less than 10% were actually under the care of a movement disorders neurologist. So for those of you, just to make sure everybody's on the same page, so anybody who's a neurologist goes through 4 years of training. So after you finish medical school, you go through 4 years of training. It's a year of internal medicine and then 3 years of neurology. But then you can then what we call subspecialize. So you can do, so movement disorders would be things. So I did an additional 2 years of focus training in movement disorders. So things like Parkinson's disease, obviously, but other things like what we call dystonia, ataxia, Huntington's disease, other types of tremor, right? Things that are not just related to Parkinson's. And then obviously there's other subspecialties for epilepsy and for stroke. And what we know is, a lot of general neurologists are fantastic, but just because they see so much of everything, sometimes it's hard to keep up with the nuances of the medications for Parkinson's disease and a lot of the subtleties of it. There's a ton of medications for Parkinson's that are available, and right, it's not just you're on or you're off for a lot of them. A lot of times it requires a lot of tweaking and, should you take more here and there? And we know that people who see movement disorders neurologists at least once a year have better quality of life, less risk of adverse outcomes or side effects from their medications and treatments. So it's not just me saying everybody should come see a movement disorders neurologist because I am one, but we do know that it can actually help improve your quality of life as well. So the problem with this, right, is that hundreds of thousands of people actually don't have access to specialized care. But also for innovative clinical trials. There are a ton of clinical trials that are available right now for Parkinson's disease, and some of them are treatment-based, some of them are observational, but a lot of our patients, in fact, over 50% actually have never been approached about the possibility of being in a clinical trial before they come to see us, and so that's something else that we focus on. So what we are, Synapticure, is we are a company. So I always say, what can you expect? So we are a company with comprehensive virtual care. So virtual meaning telemedicine, everything is done over the computer. With specialists that include neurologists. And then we've actually just hired a few psychiatrists and psychologists for our behavioral health program as well. Everybody that joins our program gets a care coordinator, and I'll run through this in a little bit more detail in just a moment. A care coordinator, so that is your point person. That is the person that helps coordinate physical therapy, speech therapy, occupational, not just getting a prescription and saying you should do this, but actually helping you identify resources that are near you, that ideally are Parkinson's specific. If we can't find Parkinson's specific, then at least somebody who's specifically trained in neurology. We are covered by most insurance companies, and we're working on getting into the others as well. And in addition, we help with things like prior authorizations, insurance navigation, disability. That's a big question we get is, should I think about disability and how do I navigate that? And I think most importantly is we work with your current team. And so our goal is to not replace the care that you're getting, but to actually augment the care that you're getting. Because for so many people, they say, look, I love my neurologist. I love the group that I'm working with. I don't want to give that up, but I wish I had this, or I wish I had that. I wish I could see somebody more often. When something comes up and I have a question, I wish I could check in with somebody more often, or, my office is great at this part of it, but, I have trouble getting access to this part of things. And so our goal is to really work with your local team, whether that be a primary care doc, or a general neurologist or a movement disorders neurologist to really help fill in any gaps that might be there. And we've worked closely with several patient advocacy groups. So we recently, Michael J. Fox Foundation signed on as one of our advisors. They've helped us build an expert patient and care partner advisory board to really make sure that we're not tone deaf, that we know the things that we think are important, but we want to make sure that we're hearing from patients and their care team what is important to them as well and what's not being addressed. And we've also worked with the APDA, PMD Alliance, and PD Avengers as well. And I think one of the most unique things is that, between all of the neurologists, we are actually licensed in all 50 states. So it doesn't matter where you are or where you travel to, we're able to see you in any state. So I have one patient that travels between Hawaii and Alaska, so I'm able to see that person regardless of where they're located. I have other patients that will travel from, so let's say I have a close friend of mine who's in New York, and she's actually sent a few patients to me that says, hey, listen, during the winter months, my patients go to Florida or they go to Arizona. Is there any way that you could check in with them, during those months to make sure that they're still getting adequate care? And she knows, the neurologist knows that, I'll communicate with her about any recommendations we make, and I'll reach back out to her to say, hey, listen, this is something that we're thinking about doing, just to make sure that we're all on the same page. So a little bit more detail about Synapticure is, as I mentioned, we don't just see Parkinson's disease, we see some other disorders as well. The company itself was founded in 2021 with support from leading healthcare and technology investors, but we opened our clinical doors in June of 2022. And since that time, we're rapidly growing. We have an NPS score, a net promoter score of 96. I had no idea what this meant when I started with the company. What it means is when you get those surveys after you have any kind of service and it says, how likely are you to recommend this service to a friend? This is where that score comes from. And it's a range from -100 all the way up to +100. So a 200-point scale. So really anything above about 60 to 70 is considered really good. And ours is at 96 right now. So I think a lot of what it is that we're hearing from patients is they love the amount of time that we're able to spend with them. So generally speaking, our new patient visits, so first time seeing us, is about an hour and a half. And then our return visits are an hour. So we have the time to really address issues that come up. We can make them longer if we need to, especially if we know in advance. And we often see patients every 2 to 3 months, sometimes sooner. I have a couple of patients that I'm seeing once a month right now because we're making some changes and they just feel more comfortable if we have that ability to just check in. And then other people I have that, maybe they do have access to a movement disorder center and maybe they see that person every 6 months. And so we'll kind of leapfrog and see them the 3 months in between. So maybe we see them every 6 months. So currently we're seeing ALS and then another disorder that's similar called PLS, as well as Parkinson's. And as I mentioned, we're expanding into some of these other disorders as well. So I think an important thing is, we were founded by a patient and his family. And so that is really at the core of what we do. Our two of our co-founders, Brian Wallach and Sandra Abravaya, are pictured here in the center with Barack Obama. They were both attorneys on the Obama administration. Brian was diagnosed with ALS at the age of 37. It was actually the day he came home with they brought their second daughter home from the hospital. And so they had a lot of knowledge on the legislative side of things. They had a lot of knowledge on some science sort of things based on some of the work that their family does. And even with accessing all of, many of the top centers and top care, they still felt like there were gaps that were in the care that they were getting. And they knew that not everybody had the same luxury that they did to be able to go to a lot of these centers. And so that's really where we started. And that's at the heart of what we're doing. And this is on the top right is just the team of our neurologists that's up here. And this is just one quote that I think really speaks to a lot of what we're doing. Is this person says, "I'm grateful to Synapticure, which filled an essential gap in my first year of diagnosis. My care coordinator and neurologist have made my diagnosis bearable and really pushed for access to specialists and treatments and supplies. Great support for my caregiver too." So again, we would love to work with the local team to make sure that whoever is with us is getting the best care possible. And so that could be an in-person neurologist or clinic. We've actually done some work with some bigger health systems. I mentioned the advocacy groups and some local communities as well. So a frequent question we get is, who uses Synapticure? What kind of people, am I the kind of person, like, what would I get out of it? How could I use it? And so these are just a couple of examples. These are some of these are blends of patients, just to protect privacy. The names obviously are not real people or real names, just to protect privacy. But this is Laura. She's 44. She's an actor that is really looking to hide her symptoms and her management. She's still working and would like to be able to work for as long as she can. And she doesn't have time to skip work all the time to head to the Center of Excellence that's actually several hours away for her appointments, for her medication refills. They have a great PT/OT program, physical and occupational therapy and speech therapy, but it's just too far for her to make those trips all the time. And she wants to be careful that people aren't asking, well, why are you missing so much work? Why are you off so often? So for her, Synapticure has been a great option, especially with her long filming hours and when she's out of town or on location, that we're still able to see her regardless of where she is. This is John. He lives in Arizona. He's embarrassed to discuss, he's okay with the tremor and some of the slowness that, other people can see, but he has some other symptoms that he's been very, hesitant or embarrassed to discuss, some non-motor symptoms related to his mental health. And some sexual dysfunction and side effects from some of his medications. So he's still working. He works 10 to 12-hour days, and he really needs flexibility of when he can see a physician. Most of the time, the doctors that live near him have not been able to accommodate his schedule. And so he's actually going to the emergency room or urgent care in order to get refills or address any issues that have come up. And so we would be a great option for him because of our flexibility with time. This is Juan. He is 72. He lives in Idaho. There is no Center of Excellence where he is, and he travels once a year across the mountains to Seattle. But during the winter months, he's not able to make that trip. He's otherwise reliant on his local primary care, who's amazing, but is not a neurologist and hasn't done all this training and doesn't know much about the different medications and the nuances of managing them. So because of where he is, he does not have access to clinical trials, and he's curious to know if he's eligible for DBS or deep brain stimulation, one of the advanced therapies, but he doesn't really have any way of knowing without getting to Seattle for his next appointment, but that's 8 months away. So he was able to access us and find out if he might be eligible. And sometimes we're able, because we work with some local teams, we're often able to expedite some appointments for sooner visits as well. And this is Amy. She's 57. She lives in Texas, and she's been exhibiting some odd symptoms. They thought Parkinson's disease, but now they're not really sure. So her local physician is recommending some treatments to manage symptoms, but, she's a little concerned because she's, what if it's not Parkinson's disease? Should I still be taking these medications? And so she's not sure if she should start these. The first appointment that she's able to get with a local movement disorders neurologist is about 9 months out. And as she debates about starting these medications, she unfortunately was not told that she might actually not be eligible for some clinical trials if she starts them, because her local primary care was not aware of this, nor should they be, right? This is not their specialty. And so this was just not something that they were aware of. And so, we were able to get a patient like this in, make the diagnosis of an atypical form of Parkinsonism, or so there's Parkinson's disease, and there's some other disorders that kind of look like Parkinson's, but not quite. And so we were able to get her on the right path for treatments and potentially some clinical trials. So if you are interested, and I'm happy to answer any questions, so feel free to pipe in at any time, but if you wanted to learn more, then you can go to our website, which is www.synapticure.com. And so this is the top of the page, and you can click on a couple of different links at the top. So if you click on the How We Personalize Care, there's information about the different diseases that we see. There's information about the different physicians that we have. And then, information about the insurance coverage, who we're covered by at the time, as of right now. We have a frequently asked questions link that you can click on as well. If you click on the About Us, we have a blog, so we post all kinds of different topics. Sometimes we do webinars, and so I did one recently, actually just last week, with Dr. Catherine Lefevre about lifestyle medicine and Parkinson's disease. We did one with Ray Dorsey about TCE and other environmental exposures. So there's all different kinds of webinars that we do, so you can watch those there, but we also write about topics that either we frequently get questions about. I usually do a summary of the webinars as well. If you don't have time to watch the whole thing, you can do a quick, a quick read to see what it was about. And we put lots of links in there too, so you can read about more information if you're interested in learning about it. You can learn about the rest of our team, and then also some more information about the groups that we're collaborating with. So if you wanted to, the first visit to book with our care coordinator, if you click here, is actually free. So if you were to click on this link, then it takes you to this page where you can, like I said, book your first free virtual visit. You just put in your name and your email. And then you click whether you're the patient or maybe a care partner. There's actually also a page if a clinician would like to refer you as well, that looks quite similar to this. You click what you're diagnosed with, or if you're not sure, then you can click unconfirmed. You pick what state you're in. So I'm in Georgia. So if you do that and you click on next, then it will take you to a page where you can actually pick out your own schedule. So it gives you the available days and whatever times you want. You click on that time, you fill out just a little bit more information, and then you will get to meet with one of the care coordinators. And they'll really walk you through more specifics for you about, what we do, if we're covered by your insurance, what your expected copay would be. So typically we're just the same copay as whatever a specialist might be under your insurance, but we can confirm that. And if we're not covered by your insurance, if we're considered out of network, then we can give you an estimate of cost as far as that goes as well. But they'll talk to you about all the different options that are available. If you do decide that you'd like to proceed with a physician appointment, they'll help you collect all your records so that we can review those ahead of time. One of the biggest complaints that we've gotten is, as we were building this program, was I wait all this time for this appointment, and then I spend almost the entire time talking about stuff that's already happened, right? Going all through the history that I've already given multiple times. And so we always try to review all those records ahead of time so that we can really hit the ground running. I'll ask questions if there's certain things I'm not sure about, or I'll try to give a quick summary and say, this is what I understand from the records that we have. But I still have some more questions. So can we talk about this? And usually what I like to focus on in the first visit is what bothers you the most? What is it that if we could work on one thing or two things today on today's visit, what is it that bothers you the most? And then see how we can try to address those things. So again, what this would look like. So once you enroll, then you would connect with your care coordinator, typically within a few days, as long as it fits with your schedule. The care coordinator does all of those things that I just mentioned. And then once they collect all of your records, then you make the appointment with your physician. And as I mentioned, because of the time that we're allowed for these appointments, these are really unrushed. We have time to spend, we have time to go over questions. A big part of what we do is education. So not just symptoms and medication management, but really education about what specifically is the underlying sort of pinnings of Parkinson's disease, why we choose one medication over another, and why it might be different for one person versus another. And so really talking about a lot of those things and trying to dispel a lot of the misconceptions about, well, when can I start medication? And I thought I was supposed to wait as long as I could to start Synamet, and I can't increase my Synamet because it will cause dyskinesias. And so we really talk about a lot of that as well. And then typically, depending upon how much we address in the first visit, we will often talk about clinical trials. Sometimes this may be the second or the third visit, depending, but we definitely do a clinical trial review as well. In addition, if needed, we have our own genetic counselors. And so if we feel that either that genetic testing is warranted, or if you're interested in genetic testing, then we do have a genetics counselor that we can refer you to that can walk you through the different tests that are available. Again, we can do a benefits analysis and see how much it would cost for insurance. Because in a lot of cases, right, it's a little easier if it's a clear, oh, I had my mom and her sister had Parkinson's disease and then her father had it, right? Sometimes it's a little more clear if there seems to be a genetic component, but not always. And because there are so many clinical trials now that are coming that are dependent on a genetic mutation or a genetic subtype, this is becoming more and more important for us to check. As I mentioned before, we've just launched our behavioral health program. So this is a couple of psychiatrists as well as psychologists that can help. A lot of times we'll try to address those during your visit, but many times if you want to see somebody specifically for therapy, or if we've tried to make some adjustments to medications, or you have a complicated history with different medications for maybe depression and anxiety, then we could refer you to the behavioral health program as well. And then, as I mentioned, we have insurance navigation, financial guidance, disability as well. So all of this is done. And like I mentioned, we would like to communicate and if needed, coordinate with your existing team. So if you have a team that you're actively involved in, then we're happy to be involved to be able to communicate with them. And what that looks like for each person is different. So I have some people that say, I want you to send me the recommendations and then I'm going to talk to my local doc and we'll make some decisions together. Other people say, I need relief right now. Let's make the changes and then just let my local team know. And then other people say, well, if you could talk to my physician and you guys could put your heads together and see if you agree, and then just let me know what the decision is. So we can tailor that depending upon what your needs are, and then also what the local clinic is able to do. And so your local, primary care or neurologist would still continue to do in-person visits because there are some things that we cannot do over telemedicine. There's certain medications we can't prescribe. And so those would still be done. And obviously, if there's an urgent issue that comes up that we can't evaluate over telemedicine, then that would be done locally as well.
Yeah.
So after your initial visit, you will continue to get monthly care coordination check-ins. So these can be by phone or by video. Just to check in, make sure you're not having any new issues that have come up, making sure that if there was anything that was prescribed. So there's always a care coordinator will check in with you within a couple of days after the physician visit to review the plan, see if there's any questions that have come up, or, if there's anything that you need help with as far as identifying, maybe a physical therapist that does Parkinson's therapy or something like that. But then after that, you'll do monthly check-ins, and it could be something short is just saying everything's great. I don't need anything right now, to, hey, listen, we've had a major issue come up and, I need something now. And then, as I mentioned, we'll do the physician visits typically every 2 to 3 months. But that is certainly flexible depending upon what your specific needs are, whether we go more or less often. So in summary, we are a team that does comprehensive virtual care. And I think the biggest thing is we really, really, really try to be compassionate. A lot of what we do is we want, I always tell people, when I was sort of a bright-eyed and pushy-tailed medical student, this is what I thought about. This is the way I imagine being able to care for people, right? Being able to spend time, being able to get to know people. I get to meet, right? That's the nice thing about virtual, is family members can join from wherever they are. I get to meet family members. I get to meet dogs and cats and grandchildren, and I get to travel with people, and I get to see all kinds of fun stuff. So it's really a chance for us to get to know you beyond just a diagnosis, right? It's not just sort of cranking it out, but to really get to know you and what's important to you and the nuances of your specific symptoms. Because if you've met anybody else with Parkinson's, that sometimes your symptoms could be completely different than somebody else's. And so it's not just us reading a book saying, okay, well, this is the next step, this is the next step, this is the next step, but really understanding what's important to you and how we can try to make you feel better. We have I think one of the unique things that we really have is the care coordination and care partner support. As I mentioned, the referrals to clinical trials, we are covered by most insurance. About the clinical trials, I will mention, so depending upon how interested you are, I will often, we can go through some of the databases together. We can talk about what trials are available, depending upon how comfortable you are. Some people like to go through the list on their own and then come back and talk to say, okay, well, I'm really interested in these 3 things. And so we'll talk a little bit more about those. At this time for Parkinson's, we are not running any of our own clinical trials. That may be a possibility in the future. But right now, because of the connections we have with a lot of the clinics, we can reach out on your behalf and say, hey, listen, we have somebody that might be a good candidate for, X trial that you're running. And we can find out more details about it. We can give you information about how often you have to go in and how many visits are in person versus remote, and, sort of what procedures might be involved, to make sure that it's something that you might be open to before you waste your time, going in and going through an evaluation. You have access to us all, care coordinators and physicians, by email. We also have a patient portal. So you have frequent, interim access to us. Again, the goal is to work with your current team, and we are available across the nation. And really the goal of all of this is that you truly deserve more personalized, compassionate, and timely care.
There's a couple of questions. We'll finish up and then we'll ask the question.
Okay, yeah, this is the last one. So this is a common theme in our practice, but I've always loved this quote attributed to Hippocrates, is to cure sometimes, treat often, and comfort always. So that's really the goal of what we're here to do, is to really be part of your team, to be able to offer more support. And if you'd like to learn more, you can either go to our website, as I mentioned, synapticure.com. You can use your phone photo, app to scan this QR code if you want. And then the one thing I didn't mention is if signing up on the website is something that you're just not interested in, or you don't want to fuss with it, you can always call us directly, and we're happy to walk you through and help set up those initial appointments, on your behalf. So I will stop there. And yeah, any questions, Sharon, that you had that have come up?
Yeah, there's a couple of questions that came up, and let's stop sharing your screen so we can see everybody who's with us today. We've got, how many people do we have? I don't know. It's 23 people at the moment. Okay, so a couple of questions. Barbara asked, how does your service compare to concierge medicine? And what is the average caseload for your neurologists and care managers?
So to start with, so concierge medicine, so we are covered by insurance. So this is not a subscription service. This is not something that you have to pay for beyond your insurance. So in that sense, it's different. But the goal is that this is essentially like a concierge program. We try to keep our caseloads low. We don't have a set number. I'd have to figure out. It sort of depends on, some of the physicians work more or less hours. But as I mentioned, because our visits are so much longer than the standard, in-person visits. So typically an hour and a half for the first visit, and then at least an hour for the follow-up visits. Our caseloads tend to be very low, and because we see people so often. So I'd have to go. I don't actually know the number at the moment. I'd have to go back and count, but it is certainly orders of magnitude less than what I have had in the past. To the point that I know I know people by their names, right? I don't have to go look up and say, wait, which person was that again? I'm able to really get to know people. And then, what is the average caseload? So the goal is that, we have the time to follow up on all of these things. We have the time to answer questions, to hop on, if there's issues that come up urgently that we can hop, we have space to be able to fit you in if something comes up urgently as well.
Okay. All right. Deborah asked, can you offer palliative care?
So this is actually a really interesting question, because so we are not technically palliative care docs, but what we have is quite similar to a palliative care model, where the goal is really about not just treating the disease itself, but really improving quality of life. We are actually, our founder, Brian Wallach, is actually being honored by the International Neuropalliative Care Society next month as Advocate of the Year. And so we're actually going to that meeting to really sit down with a lot of the neuropalliative docs to make sure that what we can address on our own is we're doing it to the best of our ability. but hopefully to be able to have those connections as well to specifically to docs that do palliative care. Because we feel like it's so important to, right, to not, this should not be something that happens, you know, in the late stages, but this should be something that should be available from the beginning, right, from the get-go. To answer clearly, we do not have palliative care docs at this moment, but this is very much our model, and we're working on building that out as well.
Susan asked, are you connected with the telemed trial with Ray Dorsey?
So we are not specifically doing the trial with Ray. He's actually one of our clinical advisors. I've known him for quite some time. He is one of our clinical advisors. I'm actually adjunct faculty at Rochester as well. At this point, we're not involved in the trial. As I mentioned, because we're so new, we're still establishing ourselves as a clinical trial site. But hopefully that will be something to come soon.
And LA, I think, are all the docs movement disorder specialists?
So because we see other disorders, not everybody is a movement specialist. So some of our docs are neuromuscular, so they would see the other disorders. I am movement disorders trained. Dr. Tom Faber, who's another one of our docs, is not, he's not done a movement disorders fellowship, but he's been very involved in movement disorders for his entire career. He used to be part of the Movement Disorder Society and really involved with that as well. So he's been kind of grandfathered in because he's been doing it for so long, because for a long time, not everybody did fellowships. It was just something that you would sort of concentrate in. So he's done a lot of work in that area with both movement disorders and dementias. And that's the two of us right now. We're looking at some other physicians as well right now, but yeah, that's the answer to that question.
Any other questions? Just feel free. It's not a big group, so either raise your hand or just unmute yourself and ask questions. Sue, unmute yourself. We can't hear you.
Susan, we can't hear you, Susan. Unmute yourself.
Can you hear me now?
Yeah.
Okay, I have a question. I am in the very beginning parts of trying to be diagnosed for Parkinson's or some movement disorder. Have an appointment with the neurologist because I couldn't get into a movement disorder specialist because she was booking 2025. I mean, I'm not wasting my time by seeing a neurologist and going through that and then going through the same thing again, or is a recommendation maybe to see the neurologist and then maybe contact your company and help me move forward, so to speak.
Yeah, so either way, so I think, you know, certainly seeing somebody in person, because there are definitely things that we can't do via telemedicine, right? So we can't check for things like sensation, we can't check reflexes, we can't, so things like that are, you know, we just haven't figured out how to do over telemedicine yet. So I think it's really good to have an in-person evaluation. So for some people, they will see their local neurologist first and then partner with us as well to help kind of move that along. Especially if they do get a diagnosis of Parkinson's or they think that's what it is. We do have some people that will actually come and they don't have a confirmed diagnosis yet. And so a lot of times what I do, because I still think there's benefit to an in-person appointment. I mean, sometimes if somebody comes in and they've sort of read the textbook and they're like, this is me, you know, I check all these boxes. Then sometimes we'll go ahead and start with treatments, but a lot of it is also, you know, checking labs to make sure that there's nothing, you know, from a lab standpoint that could explain what's going on. You know, we check MRIs typically of the brain. If it's, we typically don't see anything if it's Parkinson's disease. The MRI does not show Parkinson's disease, but we look for other stuff, right? Make sure it's not vascular disease. So just like you can have, you know, heart disease or a heart attack, or cardiovascular disease or heart attack. You can also have cerebrovascular disease or disease of the blood vessels in the brain, or a brain attack, which would be a stroke. So we look for things like that might explain also what's going on. But really that scan is to rule other things out. Okay. And then there are some relatively confirmatory tests that we sometimes use. So things like a DOT scan, there are some skin biopsies that are available now that can help make the confirmation of the diagnosis. We typically don't use those unless there is there's concern that it might not be Parkinson's. And some of it's just comfort level. Some people say, you know, I get it. Like I get that I check all the boxes, but I would really feel better if I had, you know, a test that said, this is consistent. So that's something that we just discuss on a personal level as for each person, what, you know, what we would recommend for that particular person. And then again, what, you know, comfort level is for each person as well.
Thank you. Thank you very much.
Karen, you have your hand up. Unmute yourself, please.
Earlier you were just mentioning clinical studies. So a lot of us, you know, it's just hard to remember everything. And, you know, knowing if you have 2 mutations that are of use to clinical studies, but you're limited geographically or unable to travel, can you help with that? Or, you know, just trying to find, because like, you know, it's just sometimes it's, you look at clinicaltrials.gov or any of those things, and, you know, ultimately, like what we really want is a cure. So,
Right.
how do you connect the treating MDS and say you already have a pre-established care team, but you still get lost in the system on a weekend when your medicine doesn't work.
Right.
So what would say hypothetically, I could just call up once I'm established with you, and then you could help manage me through that, say, medication emergency, or because you do get lost in the system.
Right. So let me
So-
answer the first part of that first about the clinical
know
trial.
this section.
So generally what we'll do is we would basically take, you know, your history and figure out what potential clinical trials you're eligible for, at least sort of at first pass. A lot of times there's nuances once we get into them that need to be addressed. But at least at first pass, what you might be eligible for. And then we'll talk to you about, okay, well, what locations, right? How far are you willing to travel? And sometimes it's not so much of, okay, well, I'll travel 250 miles, but it's like, okay, well, I'll travel 25 miles, or, you know, my kids live in, or I have a sister that lives in this place. So if it was in this, you know, across the nation, but it was in, you know, Raleigh or whatever, Atlanta, I would be willing to go there too, because I have family there. And so we can search different areas based on what your specific, you know, willingness or needs are. And then once we identify something that you might be eligible for, then we'll reach out to the local, whoever's running that particular trial, and say, hey, listen, you know, this is what we're thinking about. You know, we have somebody that might be eligible. You know, what do we need to do? You know, can you give me I always ask for specifics. What are the visits? Like, how often are the visits? How many of them have to be done in person, and how many can be done virtually? Because a lot of times it may be like the first and second visit have to be done in person, and then like the last visit, but the other ones could be done potentially remotely. So we'll find out sort of more specifics about that. And then we will connect you with that team if that's something that, you know, that both you're open to pursuing. And then if the team feels like you might be a good candidate as well. So that would be how we would work the clinical trial. So it's very dependent on what your specific, you know, needs, wants, you know, willingness to travel would be. And then as far as in between visits, we are, you know, absolutely happy to help out. I check messages over the weekend as well. We are not set up as an emergency service. So as always, if there's something truly emergent, it needs to be, you know, urgent care or, you know, call 911 or emergency room. So we're not able to handle true emergencies. But if there's something that comes up and you're having, you know, side effects from a medication or something like that, then we can certainly help you. Yeah, absolutely. We can help out with that. And then, you know, we can always communicate with your local team too and say, hey, listen, you know, we got a call about XYZ over, you know, over the weekend. We made these adjustments for the time being. You know, please reach out, you know, to the patient afterwards. Yeah.
Thank you.
Any other questions?
Yes, Sharon, it's Barbara.
Okay, go ahead, Barbara.
Okay. Did I miss something? Is this, is your treatment connected to clinical trials? So if you're not enrolled in the clinical trial, you don't have the benefit of your treatment?
Oh, no. That's just if somebody's interested in it, then that's something that we would absolutely help with, but you don't have to be in a clinical trial to get treatment with us.
And who would not be who would not benefit from what you have?
That's a great question. So some people feel like, so it depends. I mean, it's some of it's just comfort level. So some people may not be comfortable with it. There are some phenomenal programs that really have, they have access to everything. And if you live in the area, if you live close to a center of excellence, then it may just be easier for you to be able to get all of those things. If they're able to address all the things that you need, then you may not actually get additional benefit from what we do. So it really is person dependent. But I think I will say the one thing that we find time and time again is that so many people, once they sign up, they stay on because they really do feel like they get benefit from the programs that we offer.
How long have you been in existence?
So the company has been in existence for a little over 2 years now. We opened our clinical doors in June of 2022, so just over a year now clinically. But that's why we've really tried to work closely and, so Michael J. Fox Foundation, APDA, to make sure that, one, that people don't think we're just like Joe Schmo off the street, decided to pop up a tent and call it a clinic, but also to continue to work with them to make sure that, the things that we're doing are on target with, what, patients and their care partners really feel like are needed.
How come I never heard of you before?
Yeah, no.
So we started in ALS, so that might be why, because that's what one of our co-founders had. The plan was to always expand. So, he has ALS, but his grandfather, I think it was his uncle actually, had Parkinson's disease. And so they saw the same struggles that he had with trouble getting to appointments. And so they knew from the outset that they wanted to expand into other disorders as well. But it may be because we started out in ALS, but we've been advertised on the Michael J. Fox Buddy Network. We've been, but we're a small company. So we're, kind of doing the circuit and telling people about us now.
How long is your funding for?
I don't know the specifics of that. And I'm not sure that that's public information either, but.
Thank you. Susan has a question.
Yeah, well, I wanted something to tout the horn for, because when Susan was talking, this Susan Runblad was talking about only seeing neurologists and having to wait, this would be a terrific, this is unsolicited, bullshit suggestion. But when I was going through my diagnosis route, and I knew right away it was Parkinson's because I have a genetic component that we knew about, and but still I saw regular neurologists. I didn't know about movement disorder specialists, and it was in a major medical center. When she decided I had Parkinson's, she put me on a full dose of Synamat, made me so sick for 3 days, because she said, well, if you stop shaking, you have Parkinson's. And my answer was, if I stop throwing up, maybe I have Parkinson's. So if you're just seeing a neurologist, this is a phenomenal program for you to be attached to. So I'm not sure that Dr. Martin can brag that much, but it just really sounds like a terrific idea for many people, but especially if you can't see a movement disorder specialist for some time.
Yeah, I think that speaks to a lot of the nuances of the medications too. So the mantra is always start low and go slow. We can always speed it up, right? If you're tolerating it just fine, we can always ramp it up faster, but you always start low, work your way up to make sure, because right, throwing up and feeling horrible often can make your tremor worse, can make you feel terrible.
Well, it was such bad advice because one, my tremor was intermittent, so you couldn't really tell if it came off or not. Right. Two, I didn't go on medication for 4 years after that, not because of the experiences, because it was not a necessity for me.
Right.
So a neurologist may say, yes, you have Parkinson's from everything, but that doesn't mean they're the best person to go from there. Right. And they'd probably be really wonderful working with someone like you to guide them when you can't see movement disorder.
And sometimes, especially if tremor is your predominant symptom, some people can kind of smell the bottle and their tremor goes away, but there's some people that just have tremor that is resistant to medication. So we've had people come in and say, I was told I didn't have Parkinson's because I didn't respond to medication. And so it was either because they had tremor that was resistant to medication, or they weren't on the right dose. We've had people that you go back and you look at, videos from 5 years ago, they're like, oh, I had symptoms, for a year. And then you start going back and you look at pictures or you look at videos and you're like, oh, actually, probably about 5 years ago, we were already seeing some signs. And so when they walk in the door, they may need more than a starting dose. So we would have to work it up. But again, I think that's where it's got to be individual, right? Not everybody is going to have the same recipe. And, depending upon what else is going on in your body and in your life, then what your needs are may be different as well. So I think that's where the individual part of it really comes in.
Okay. Mary, do you have your hand up? Mary Wilson? Did you want to say something? No? You're muted if you want to say something, unmute yourself. Can't hear you. We can't hear you.
I'm going to ask her to unmute. See if that makes sense.
Unmute yourself. Okay. I'm going to go back to sharing my screen then. Mary, if you unmute yourself, let me know, okay? All right, so where are we? Here we go. Okay, so first of all, Jaime, thank you. I thought it was wonderful.
Thank you.
And I found out about Jaime about 2 months ago when she came on a call for PD Avengers. And PD Avengers is great. If you're not a part of it, you should check them out. But anyway, that's how I found out about her, and I knew that she was legitimate because of that. All right, next up, in 3 weeks, we will be meeting August 27th, and we have an opera film that has been created by people with Parkinson's who perform. They've done artwork, and it's very interesting. You'll check it out in the newsletter. You'll be able to view the film before. Excuse me, here's Parky. You'll be able to check out the film before the program, and we will have Amy Mallet, who is the artistic director, as well as several of the people who are in the film. And then after that, I'm not quite sure what we're doing because September's kind of a crazy month with all the holidays. And then also on August 27th, after her story, we will be talking about Michael J. Fox's new book, No Time Like the Future. If you have not read it yet, I would suggest you read it. I like listening to his books because it's always good to listen to him because he really puts himself into it. And take a look at the book and let us know if you want to join us. And let's see, next one. My wonderful daughter has designed a new logo for us and new products. And so we now have some stuff that is available. There's more than this, but she put a whole bunch of things together with our Twitchy Woman logo, the new one, unlike my old one here. And check it out. And what else? Peer-to-peer mentoring program. I know that we've had a couple people talk about this already earlier. So if you're newly diagnosed, looking for someone to talk to, or if you've had Parkinson's, you want to help someone else, learn to live with Parkinson's, check out our peer support program for women on the Twitchy Woman website. And looking for a chat group, we have 2 of them on Tuesday mornings. Anything goes at 9 a.m. Pacific time. We have a wonderful group. And then on Sunday mornings, before our regularly scheduled webinars, we have Twitchies Without Partners. So we had quite a few people this morning. And that's it on my end. This is my Parkies from Parkinson's Congress. We don't know, we think it will be in 2 years. They don't know where, they haven't said, but we think it will be in North America. So everybody should be able to go the next time. And I'm going to stop sharing my screen. And I'm going to turn off the recording. And any